My name's Carrie Siegel. I'm an abdominal radiologist at Washington University in St. Louis. And I have a subspecialty interest in GU imaging, but I do all aspects of abdominal imaging. If a referring physician has a patient with a complicated renal cyst, what is the best imaging modality for follow-up? Well, I'm just going to do a brief overview of renal cysts classification, and then we'll break that down a little bit. The Bosniak classification is a classification system from renal cysts, with the Bosniak 1 cyst being completely benign and the Bosniak 4 cyst being most likely a cystic renal cell carcinoma. And then everything in between sort of filtering in somewhere on that scale. The Bosniak classification system was revised in 2019. And I'll just go over it briefly, and then we'll talk about how we're going to, what kind of recommendations I might make for follow-up. First, the Bosniak 1 is just a simple cyst. That requires no follow-up at all. It's a simple cyst. It doesn't have any calcifications or septations, any areas of abnormal enhancement. The Bosniak 2 is a cyst that can have thin, almost like paper-like thin septations, less than or equal to 2 millimeters in size, and between 1 and 3 of those septations. That's it. It can be a high attenuation cyst. That means it's a bright cyst on a pre-contrast CT. And lesions with any kinds of calcification, whether they're thin or chunky, as long as they're not associated with nodules, masses, or enhancement, chunky calcifications in and of themselves are okay. The Bosniak 2F, and the F stands for follow-up, are cysts that have septae that are 3 millimeter in size or 4 or more septations. The Bosniak 2 that have had those thin 2 millimeter septations up to 3 don't need any follow-up. The Bosniak 2Fs, where the septations are 3 millimeters in size and there's more than 4, are usually followed up every 6 months to a year for approximately 5 years. The Bosniak 3 cysts are even a little bit more complicated. They tend to have septations that are about 4 millimeters in thickness. And the Bosniak 4, they're greater than 4 millimeters. They actually have nodules or mass-like areas of enhancement. So if we think about it, the Bosniak 1 are completely simple. The Bosniak 2 are so minimally complicated, they don't require any follow-up at all. So we'll just take those off our list. The Bosniak 4 lesions are presumed cystic renal cell carcinomas. Those are usually treated with partial nephrectomy unless there's some compelling reason not to, patient's age or comorbidity status. So the only lesions we're really seriously dealing with are the 2F and the 3 lesions that are in that sort of in-between category. Those are usually followed 6 to 12 months for probably a total of 5 years. Now the question is, with these in-between cysts, what's the best mode for imaging them? The first thing I will say is, in large patients, ultrasound is not good. In thin patients, ultrasound can be very good. So that's one deciding factor we can use. 2 is that both CT and MR are good in evaluating these complex renal cysts. I mildly or maybe even moderately prefer MR over the CT because we just get much more information. When you think about it, we do a CT for a renal protocol. A lot of times there'll be a pre-contrast and a post-contrast scan. Sometimes there'll be a pre-contrast, a post-contrast, and a delayed scan. But that's it. We don't continue to scan additionally because each scan is an additional series of radiation exposure. But with MR, once we've given the contrast, we can get arterial phase images, cortical medullary, nephrographic, delayed. We can do all different kinds of things because there's no radiation involved. So additional sequences through time are really only a hit to the radiology department because the person's on the scanner longer. And maybe they're a little bit more uncomfortable for the patient because the scan might be a little bit longer. But it's the same dose of contrast and there's no radiation exposure at all. So with the MR, we can get much more images through time. We get a little bit more information with how bright or dark the lesions are on T1 and T2 weighted sequences, and our diffusion sequences are important too. So we get sort of a lot more information on the MR. The CT might provide a little bit more information on calcifications, but as I mentioned earlier, calcifications in and of themselves that aren't associated with nodules or masses or enhancing, we really don't care. So the long and short of it is ultrasound's a possibility in slim patients. CT and MR are both options for complicated renal cyst management. And for multiple reasons, I prefer MR over CT. If the patient were to be claustrophobic and or have some sort of bullet or metallic device or pacemaker where we weren't able to do an MR, we can get very good follow-up imaging with CT. I just prefer MR. If for some reason, and a lot of times with complicated renal cysts and with other renal masses, our issue is something enhancing or not? And if for some reason the patient could not have gadolinium for an MR, or also could not have iodine-based contrast for a CT, then we have options with ultrasound-based contrast agents. And there's a question coming later where I will discuss in more detail ultrasound-based contrast agents and how that'll fit into this question.